All right, we're going to pick up with coronary artery disease where we left off. Hopefully you guys learned something from your Tuskegee Airmen or the Tuskegee experiment paper. No, we finished the heart. So now we're going to talk about coronary circulation. This is circulation to the heart specific. Okay, so you guys know that there are coronary arteries. Why do we need coronary arteries? How can you not see that close?
I'm blind.
So why do we need coronary arteries? Blood flow to where?
The heart.
So
Everywhere, man.
well, it's to the heart itself. They supply all the nutrition and the actual blood to the heart muscle itself. So you have a left and a right coronary artery. So your left coronary artery has two branches. The anterior intraventricular branch, it supplies the ventricular, the ventricles, the septum, and the atrium on the right side, and both of the anterior walls, both sides of the anterior walls and the posterior walls. So you have, I really want you to remember that you have a left and a right coronary artery, and that the left coronary artery has two branches, and it supplies blood to the front, anterior, posterior parts, can't talk today, of the heart.
Okay, it has two branches.
Has two branches, and it supplies blood flow to the both ventricles, the septum on it, and it supplies blood to the anterior, posterior parts of the heart. I don't care so much that you know the location as much. I really want you to know that it supplies blood to the left side of the heart and the septum. And it supplies some blood flow to the anterior and posterior. What does that mean? Anterior, posterior. Front and back. So the left coronary artery has two branches that supply blood to the front and back, atrium and ventricle, and to the septum. You have two branches. The right coronary artery also has two branches. What do you think it does?
The right side.
Does the same thing to the right side, right? Supplies to the posterior walls of the ventricle and the right atrium. So let's see. So you can see here, here's your right coronary artery, and it comes out of where? See where it's branching out of the aorta there? It comes down, and it gives blood flow to the right atrium, comes down, gives blood flow to the ventricle, anterior posterior portion of the ventricle. Then here's your left coronary artery, and it branches, and then it has actually some sub-branches as well that supply blood flow to the right anterior posterior parts. Now, which one do you think gets, by looking at this picture, which coronary arteries do you think they have to bypass the most often with CABGs, with bypass surgery?
What did you say again?
By just looking at their location, which arteries do you think that become clogged that they have to be bypassed most often with? The right or left?
The left, because I was looking at opposite. The left is more exposed than the right.
The left, that's part of it. Also because that's the part that needs more, it has more actual muscle, does more work. So it's gonna, even though they both have blood flow going through them, you know that the left side of the heart does more work.
I was looking at it the opposite way. I was looking at the left side, the right.
The left side because it ends up having to do the most work. It also has the longer branches, has more branches in it, right? From the two main branches, it branches off even more. Okay, so this is another picture showing you coronary artery one, the coronary arteries on the posterior side of the heart. So you can see where they wrap around. Anastomosis. What does anastomosis mean? Anybody know what anastomosis is? Big word. Just means connection. So if we perform an anastomosis of the colon, we remove the section and then add it together. And when we bypass coronary arteries, we actually take a vessel and graft it on, and that's called an anastomosis, where they connect. The anastomosis of your regular coronary arteries are basically the point where the vessels join. They come out of the aorta, and then the branches where they branch off, those locations where they come out of the aorta and where they branch, that would be the anastomosis sites. So I answered that for you. They join where? Where do they connect? The aorta. They come out of the aorta, then they branch into 1A, 1B, and then 2A and 2B, right? Coronary arteries A and B. So they provide blood flow to the tissue, the actual. Can't talk today. They provide blood flow and nutrition and waste removal directly to the cardiac tissue. So that's what it would look like if you couldn't see all the heart muscle. You can see where the right and left coronary arteries branch around into the heart and feed the muscle. Have you guys finished your diagrams I gave you a while back? I would get on that. Because Monday, you guys are having a
Okay, can we not do it on Monday? Because Monday, like, what about Tuesday? Because
no, Tuesday don't work. No, Tuesday, because here's the thing.
well, Mondays don't work.
Monday and let's see, Monday, Tuesday, and Thursday, there are things going on at school I have got to take care of. And Monday does not relate to Wednesday. High school stuff.
You said Monday,
Tuesday, and Thursday. We still got Wednesday. But I need us to move on. Okay, Monday, I have to work at the junior high track.
Okay, then you got time to work.
Tuesday, I will be gone all day next week. Wednesday, we need to continue. We need to finish up and start. We need to test Monday because Wednesday we need to start a new.
What did you say?
Yeah, negative. Wednesday we need to start a new unit. Thursday, we have Bulldog relays, and half of y'all are gone other places anyway. And then I don't give tests on Friday.
Well, we don't need to get tests on Mondays. That's bad.
Well, normally I don't, but that's the only option because I am not having a sub give a test. So Monday you will have the anatomy portion because what you're doing Wednesday when I get back is I need y'all to dissect the heart. And that means Friday your lab report.
Friday, Thursday, and Friday.
Well, somebody in your group better finish it up. I'll give y'all your own groups. I'll assign you your groups. That way somebody will be here to turn it in. That works.
Well, Keegan will be here in our group.
I didn't say she was in your group.
I'm just saying.
Okay, so talk to me about what you know about chest pain and heart attack. Tell me what you guys know about angina or chest pain and heart attack. What do you know about them? Okay, they're painful. Why do they happen?
Oh, I was talking about chest pain.
Tell me some reasons people would have chest pain or a heart attack. Anxiety can cause chest pain.
Anger issues.
Not eating right. Other health issues. Smoking. Blood pressure issues. Blockage. So what happens in a heart attack? You may know what actually happens to the heart in a heart attack?
It collapses.
No.
Stops working. Don't you like tense up?
No, that's an arrhythmia, not a heart attack.
It starts working too hard.
No, that's cardiac arrest. It's a heart attack. A heart attack is when the heart loses oxygen to a certain area. Like one of the coronary arteries is blocked, and maybe it loses oxygen to the posterior lower ventricle. That part of the heart dies. It does not repair. So it could be due to a clot. It could be due to constriction of some reason, whether it's narrowing, blockage, whatever, some kind of blockage that's causing that, so there's not getting enough oxygen.
Okay, didn't you say that's what happens with a heart attack, right? And you know, like some people don't die when they have a heart attack. How? If your heart's like not working in a spot.
It depends on how much of the heart is damaged. People sometimes have what is called a mild heart attack, and it does. Mild heart attacks only cause minimal damage. So angina pectoralis, that is what we call chest pain. I would probably know that word because it's in. That's a partial obstruction of a coronary artery that prevents blood flow and it causes chest pain. Is that going to be permanent? In angina pectoralis, is it always going to cause damage? No, not necessarily. It may just slow blood flow and cause excessive muscle contraction. So it's usually ischemic, which means that there is not enough oxygen getting there. It can be activity related. So how many of you guys, when you run and get out of breath, have a little chest discomfort?
I think everybody does.
So that could be ischemic related because you're sucking in too much. You're not sucking in enough air, and you're blowing off too much carbon dioxide. You're performing anaerobic exercise.
Are you basically saying like you hold your breath for like a minute or something, like do an exercise?
You know, or no, but you know, whenever when you run and you're like really short of breath and you're breathing out, but you're having a hard time getting air in, that causes hyperventilation, which increases the carbon dioxide content in the body and decreases oxygen supply. If you do that for long enough, prior to passing out, you'll have some chest pain, and it's related to the change in the oxygen level.
What I was getting to is what I learned about myself was whenever I like hurt my back, and I was in PT, we did a lot of like core exercise, like planks and everything. And the guy that was like my PTA, he noticed that like I would hold my breath when I was doing stuff, and he was like, breathe. I'm like, I am.
You're not.
Yeah. You're not breathing. He said, that is not good. You need to breathe when you're doing stuff. And every time I work out, I notice that if I go down to do a squat, like I'm not like breathing or anything, I can hold my breath. And I don't know why. I do that what I want to do. Like if it's a whole 30 yards, I'm gonna hold my breath till I get there. Yeah.
So that decreases you utilize your oxygen up. You have to think about it. Myocardial infarction, that is a heart attack. That's what the medical term for heart attack. That is a complete obstruction that causes cardiac death. That means the cells die. There is when someone has a cardiac arrest, tell me what do you classically know people complain of with a heart attack? Left arm pain, chest pain, neck pain, jaw pain. They get diaphoretic or real clammy, short of breath. What about women? That's classical symptoms for men. What about women? It's not always the same. Women will have mid upper abdominal pain. Sometimes they'll have right-sided chest pain, radiating down to the right arm or right jaw. Sometimes they usually do get short of breath, but lots of times heart attacks in women are misdiagnosed as indigestion because they complain of upper epigastric pain and not chest pain. Now, the reason why we consider left arm, neck pain, left-sided chest pain, we consider those classic symptoms is because for about 60 years, 90% of the studies for cardiac-related disorders were done on men, not women. And so we just blanketed that. So that's where there is a campaign, to wear red for women's cardiac awareness. It's because it raised money to start doing cardiac studies. And I have actually seen that in action. In the emergency room, I had a lady come in, and I was a pretty new nurse. She was complaining of upper epigastric pain. She said she felt nauseous. She felt like she needed to throw up, and she did throw up. She was clammy. Well, you know when you throw up sometimes because you're hurting, you will get clammy feeling. And that was my first hiney chewing from the doctor because I called myself. I think we have a lady out here with indigestion. I told her what's going on. He said, "Did you do an EKG?" I said, "No, but she's not complaining of chest pain." He said, "I'll be out in a minute. Get the EKG started and draw cardiac enzymes." Well, she was having a heart attack.
I thought all of them was low, something for heart attack.
Severe enough, yeah. This particular lady, we ended up catching her heart attack and giving her a clot buster and getting her in for angiocath pretty quick. And they stented her, and then she went and had bypass surgery about 6 months later. But that was something, because I was not taught that in nursing school. I was not taught that. That particular doctor is the one who taught me about the difference between men and women, male and female heart attack. So if it's your mom or your grandma or your sister, they may not present with that normal what they tell you to look at with a heart attack. Left arm pain, numbness, tingling. Now, she did tell me as I was putting the EKG on, I feel like there's an elephant sitting in the middle of and
what?
An elephant is sitting in the middle of my chest. It's a crushing feeling. And people with a heart attack, when they're the heart is really contracting and the tissue is dying, they really do feel like there's a ton of bricks or some kind of serious heaviness on their chest. She literally said, "I feel like an elephant over my chest." Between huffing and puffing, she couldn't talk hardly while breathing. Okay, so those are normal. Those are the normal signs of heart attack between men and women. Venous drainage of the heart. So 10% drains directly into the right atrium via the and ventricle through multiple veins that are coronary veins in the heart, called the basin veins. 90% return to the right atrium through the great cardiac vein. So that is blood from the anterior intraventricular sulcus. So that's where we saw that those coronary arteries, the coronary veins lay right next to them. So I do want you to know that the 90% of blood returns from those three locations. And they all empty into the coronary sinus before emptying into where? If it's a vein, where's blood flowing? What's that right upper chamber? What is the right upper chamber of the heart? The right atrium. So it has to go empty into the coronary sinus before it empties into the right atrium. So you have three vessels that take 90% of the blood, and then 10% go directly into the right atrium. 10% of the blood goes directly into the right atrium. So you have 90% that comes from the greater cardiac vein, the middle cardiac vein, and the left marginal vein. That's what I want you to remember. 10% goes from directly into the right atrium from the basin veins, and 90% just from those other three veins. And then it has to empty into the coronary sinus before it goes to the right atrium. So now you can see where all those vessels are.
I was almost done this proof. What was the last one on that one? Is the middle cardiac vein, and then what was the last one? The left something.
The left marginal vein. So see, there's your right marginal vein, the right coronary artery. Then you have the anterior intraventricular branch of the left coronary artery, the great cardiac vein. And you can see it's the largest vein running through there. And there's the posterior view of it. The greater cardiac vein, the coronary sinus. What does the coronary sinus look like to you? It's that vein, right? So, does blood from the coronary, do coronary veins feed into, because this is a question on your test, do coronary veins feed into the vena cava? No, they bypass it.
Oh, wait, just because I have an injury to you. Oh, Lord. No, it's not even that. It's a way to remove the blood flow in your heart. Vava, L, Vava. Vena cava, right atrium, right ventricle, pulmonary arteries, bones, pulmonary vein, left atrium, left ventricle, aorta.
Vava, Vava.
Vava, L, Vava.
Oh. Okay. Like L, like El Paso. Yeah.
Mnemonics are good things. Okay, so cardiac muscle and the conduction system. How many of you remember cardiac conduction from last year that took medical terminology? How many of you that took medical terminology last year remember conduction, the conduction of the heart?
Conduction.
Right, how the heart, the electrical conduction from where to where that causes what had to happen.
Yeah. I remember us talking about it, but I don't remember exactly.
Okay. So the heart has its own pacemaker. Does anybody remember what the heart's pacemaker is?
I was coming back. I should get with her last year.
Mm-hmm.
Actually,
The heart's
I think
pacemaker.
they keep it on.
That'll be the SA node. What's the SA node? What does SA stand for? Bueller.
Sinus node.
Close.
Sinoatrial node.
So how many beats is the heart supposed to beat a minute?
A lot.
60 to 100. Pacemaker square.
SA node.
CSA node. It is what starts all heart conduction. That's what I want you to remember about the SA node. Myogenic is where the heartbeat originates. So the myogenesis of the heart happens in the SA node. That is where the heart muscle, it tells it to contract. So it's the sinoatrial node. That would be your SA node. And then the SA node sends an impulse down to the AV node. Anybody remember what the AV node is? Atrioventricular.
Oh, close.
So the AV node sends the impulse where? So this causes the atrium to
Is it
contract.
an electrical impulse or something?
So it's sending the impulse from the SA node, which causes the atrium to contract. Then the SA node sends an impulse to the AV node. The AV node sends it to the bundle of His,
Which is an electrical thing.
and then that sends it down the right and left bundle branches. Bundle of His. Oh, sorry, there's no I there. Bundle of His. Then it goes to the right and left branches, and then to the Purkinje fibers. Then to the Purkinje fibers. And those. So this is the heart, and I'm a horrible heart girl. So here's your atrium, and there's your ventricle, right? This is the septum. So your AV node, your SA node is up here. And then it sends an impulse down to the AV node, which is right here. The bundle of His runs down here. Sends it down the septum, and it breaks off into the right and left bundle branches, right? And then you have these little tiny fibers that go all the way out and branch all the way out here. Those are the Purkinje fibers. So this makes the atrium, the SA node makes the atrium contract. This starts the contraction of the ventricle. Electrical conduction has to go all the way down, branch off, and go into around each side for the ventricles to contract. Because the atrium contract at the same time and the ventricles contract at the same time.
Where's the P word?
Purkinje?
For Kenji. Those fibers.
Does that make a little more sense than I just explained it, even though it's a really horrible, horrible drawing because I cannot draw to save my
Handwriting. Where's the?
Okay, so you have an SA node and AV nodes, the bundle of His, which is right down the septum, goes down the septum and it breaks into a right and left bundle branch. And then you have the Purkinje, it sends that on out into the Purkinje fibers.
E, R, K.
I just put P fibers.
Okay, I'll start with the F came from.
P fibers.
Like, I don't think I'll F. That's how I was gonna say.
So that's the electrical conduction. So I'm going to show you what it looks like on an EKG. So this is my baseline. So I have a P wave, I have a QRS segment, too high, and then I have a T wave. This is a P, this is QRS, and this is a T wave. The P wave is atrial contraction. The QRS segment is ventricular contraction. The T wave is when the ventricles are at rest. And then it's going to start over. It's going to have a little space. And it's going to have another P, a QRS, and a T wave.
P.
P, Q, R, S, and T. Now, what if, so y'all have seen heart rhythms that look like this, right? Similar. Except the T wave shouldn't be that big. That would be a 10 and T wave. What if my heart rhythm looked like this? See? Would that look normal? What does that look like? What does this right here look like?
Yeah.
It's a tomb. That's what we call the tombstone T. The only way you survive that is if you are on the table and they can directly shock the heart because you're already open. Now, what if my heart rhythm looked like this?
Live.
Maybe. What does that look like?
Well, you're not doing a little flat thing. Like, not flat lines. Oh.
My horrible drawer, remember. What does that look like now?
An
ear? A saw. That's a sawtooth rhythm. This right here, one of two things. One thing is happening and another thing is fixing to happen. So right here I have atrial fibrillation and I'm not really having any much ventricular rhythm. This is what happens next. Looks like grass. Looks like grass because if you get into that rhythm, you're probably going to be under it. That's ventricular fibrillation. Looks similar to that, and that's what we shock. What if I have a rhythm that looks like this? Grey's Anatomy fans. What am I going to do to that?
You're dead.
So I have no rhythm, right? Do I shock that rhythm? No. But do they always shock it on TV? Yeah. Yes. No. We only treat that with chemicals. Yeah. Sodium bicarb, amiodarone, hopefully resets a metabolic disorder and fixes it. Otherwise, you're like really blue and cold.
You know, like, if you go into the hospital and you get hooked up to one of those things, okay, well, there's one, like, I knew what a flat iron was, and I tried to, like, hold my breath to see if it would, like, go flat. And that little beeping sound, and it would, like, go small, it wouldn't, like, go flat.
And so with, even when someone has a pacemaker or when someone has cardiac issues that they go in for a cardiac arrhythmia, even when someone dies for at least 30 minutes after they are gone, if they don't have a pacemaker, you'll have occasional rhythms. Like you'll have an occasional blip on there because you still have some electrical conduction in the heart for a little while. It takes a while because you'll see the pulse rate go down, go down, go down, go down. I mean, someone may technically not, their heart rate is 10, then it'll be 5, then it'll be 2. But the heart takes longer to stop beating necessarily than you are still on the planet. Because technically, when you're having 2 beats a minute, you're not alive. Okay, myogenic is heartbeat that originates within the heart at the SA node. From what 1% of the heart cells does that happen? You have arrhythmic cells, or that's the conduction system. So we've already kind of talked about all this, right? Where it goes from the SA node to the AV node. I actually just made this, condensed it down to what I want you guys to really know about that. I'm going to ask you about a couple of those different rhythms that you saw. So if I ask you, if I were to draw a rhythm that looked like that tombstone, what are you going to tell me that might, what might be impending? It's definitely impending doom. You may not survive that. What if you have sawtooth rhythm? We're going to shock that to try to get back into a regular rhythm. If we have atrial fibrillation, we're going to try to treat that with a medication, and if we can't, we will shock that and try to, or at least pace it till we can get a pacemaker in. We don't really use paddles anymore. Pretty much the sticky pads. We use sticky pads now, and they just have that way everybody gets a different set of pads, and it's a cleaner process. But yeah, they're just disposable pads that hook directly into the defibrillator. It looks very similar to the ones on the AED.
Is that like, I can't imagine like if you were awake and you felt someone shock your heart comes down that way.
I've only seen that once. So we had a lady that came in and she was awake. Normally when you're in sawtooth rhythm, when you're in ventricular fibrillation, generally you're not awake. But we technically had a lady come in ventricular fibrillation that was sort of awake. She was in her 70s. We did shock her to try to get her back in rhythm because she really wasn't talking or making sense. But she was breathing. She was breathing agonally. So we were trying to shock her before we intubated her. She did come up off the table and yell "white lightning" real loud. And then she did survive. We did, we had her on the vent for a couple. I don't know why that's just what she said.
She said white lightning.
She did. I don't know. So, but she actually remembered being shocked. She told us, she cussed us up once she got off the vent, cussed us up one side and down the other, and told us we were all going straight down under the ground when we died. Because she remembered and said it was very painful. Now, generally, you wouldn't do that, but we were about to lose this 72-year-old.
I mean, she wasn't like opened up, was she?
No.
Oh God.
No, she came in. She came into the ER having a heart attack. She literally. So we already talked about the sinoatrial node. We talked about the AV node. So the sinoatrial node is in the top right atrium.
Wait, so what is the autorhythmic?
The autorhythmic cells, they are responsible for helping the SA node fire. They have the neurotransmitters that are necessary to start the SA node, the electrical conduction. The AV node, the SA node, once again, sends a signal after the atrium starts to contract. It sends that signal to the AV node, which starts the contraction of the ventricles. Then the bundle of His runs down the septum of the heart, right? So you have the AV bundle. The bundle of His branches off into right and left branches. It sends that electrical impulse through the right and left branches, then to the Purkinje fibers. And that's what causes the actual contraction of the ventricles, that strong contraction of the ventricles. What happens if there's some kind of misfiring in there? Does that happen often? Yeah, it does. Anybody ever feel your pulse and or you're sitting or doing something and you had a bunch of caffeine or you've eaten really crappy food for a while, and then all of a sudden you kind of feel like your heart's beating along normal, and then all of a sudden it'll feel like it beats real hard, one really hard beat? Have you ever felt your pulse and it'll beat along fine and it'll feel like it skips a beat? Hopefully not you guys, because y'all are so young. Because you never know. I mean, like, I've had teenagers come in from ball games or from being out at the lake all day, and all they've drank are things like Monster, Red Bull, Nas, those horrible energy drinks, and they'll have cardiac arrhythmia because they're dehydrated. And then they've drank all of these energy drinks, which dehydrated them even more, which changed their cardiac rhythm.
Okay, so a friend of mine used to drink literally like between 9 and 12 of those a day. How did this person die?
Well, it definitely sped up their heart rate.
Oh, they were a hyper person.
Well, if they have
When
80,
they did die, I figured like it's past it, so they were. It is a hyper person, but literally still drinks like 9 and 12 lawsuits.
so it's very unhealthy because they do have a lot of caffeine. They also have a lot of sodium. They have a lot of, and what is sodium? What is an excessive amount of sodium going to do? It's going to dehydrate you even more. Caffeine dehydrates you.
Did he have like immunity to it?
Caffeine is just as addictive as smoking and any kind of drug. Anybody I don't know, I don't drink anything but soda, right? All I drink is Coke Zero. I don't drink water. I don't like water. I'm not going to drink water. Occasionally I'll have a glass of tea. Occasionally. What happens if I stop drinking and I decide I'm going to just drink water? I'm going to have withdrawal. I'm going to have a horrible headache. I'm going to be nauseous. I'm going to feel like I have the flu. Anybody ever stop drinking soda that drinks a lot of them? You feel horrible for 2 weeks, sometimes even longer.
Usually when I stop drinking Dr. Peppers for a long time, I'll have migraine for a week.
Yeah, you have a horrible headache. So know the conduction know the conduction in the heart. So there's another picture. There's your SA node. Sends a signal down to the AV node, which sends a signal through the bundle of His, which is right here at the top of the septum. Then you have the right and left bundle branches, and all these little fibers are your Purkinje fibers that cause the actual ventricles to beat or to pump. What time is class over? 2 minutes. Okay, so there's another image, and then we will stop here. All I want you to know is I want you to be sure that you know the pathway of conduction. We will talk again about the P, Q, R, S, and T segments. I'll be talking until I get off this page.